everybody. My name is Charles Cast. I am an internal medicine hospitalist here at North Shore University Hospital. I've been practicing for about 15 years. I've held a couple of different leadership roles within our group and have helped to lead a number of geriatrics-based performance improvement collaboratives. I currently serve as our hospital's associate medical director, and I'm currently steering or leading our performance improvement collaborating group, which is centered around age-friendly initiatives. Thank you.
Good morning. Good afternoon. Good afternoon. My name is Joseph Delugach. I'm a retired senior vice president from Northwell. Currently, I'm a trustee sitting on the quality committee of Northwell and having a good time basically as a trustee. Today's session will be absolutely different from the previous sessions. It's more focuses on the science and the philosophy of geriatric medicine, and we have wonderful people who present their opinion and their experience in today's session.
Thank you for having me. I am Maria Carney. I am Chief of the Division of Geriatrics and Palliative Medicine at Northwell and Medical Director of Continuing Care. And we have just launched Northwell Aging Institute here at Northwell Health. And I'm a professor of medicine at the Zucker School of Medicine. And it's a privilege to be able to talk about the aging revolution that we are undertaking here at Northwell.
Hi, everyone. Thank you for having me. My name is Isabella Newman. I'm a recent graduate of the Northwell Fellowship in Geriatrics and Palliative Medicine, and I'll be joining the faculty at Mount Sinai in the fall in the Department of Geriatrics and Palliative Care.
And we want to thank Brendan Coward, who's our Senior Associate Finance and Operations here at North Shore University Hospital, who's helping us with this production and technical support. Today's goal is to equip all of you with the knowledge, skills, and attitudes necessary to provide compassionate, comprehensive, and patient-centered care for older adults that optimizes their health, function, and quality of life. The objectives today are threefold. We want to help you describe the core principles of age-friendly care. We want to apply a structured approach to geriatric and palliative care, and we want to discuss the importance of interpersonal collaboration in geriatric care. We will articulate the key elements of age-friendly care, as well as help you understand the data that we have here that shows us our patients that have physical, cognitive, and functional psychosocial domains to identify their individual patient needs and develop appropriate care plans. And lastly, really show the roles of various healthcare professionals involved in the care of these older adults and articulate the value of teamwork in optimizing their care. And I'm really delighted to be here amongst an author, Dr. Maria Carney, who wrote The Aging Revolution with our CEO, Michael Dowling, and Charles Kenny.
My first question to the panel is, how does geriatric medicine and palliative care help us to deal with today's population of complex patients?
So I'd like to tell a story that a few years ago Michael Dowling had called me, and he's the CEO of Northwell, and he had asked me to give a presentation on all of the aging services across our health system serving the population that Northwell serves. He didn't talk about a specialty. He didn't talk about inpatient, outpatient. He said he kept it very broad, all the aging services in the healthcare system. And we met for an hour, then it became 2 hours, and essentially that was the outline for what is now the book that came out, The Aging Revolution. And it really came from his thought that there's this growing population that is challenging healthcare today. And so maybe we just go into a case. And this started our initiative at Northwell. We had an 84-year-old female, a case that was presented, multiple medical problems, emphysema, dementia, hyperlipidemia. She had a history of spinal stenosis, laminectomy, osteoporosis, hypothyroidism, and in the community, she had been identified as having a vertebral compression fracture and excruciating pain to the point where it's impeding her function, and they were unable to make progress. So she was admitted to the hospital, and she was on multiple meds, seeing many different doctors in the community. If you see her list of meds, there are 3 anti-inflammatories, 1 pain medicine, tramadol with Tylenol. Then she's also on gabapentin, simvastatin for her hyperlipidemia, levothyroxine for hypothyroidism, buspirone for depression, and an inhaler for her COPD. Multiple medications, in pain, admitted to orthopedics because of her vertebral compression fracture. That was her primary reason. That first night, she became delirious. They gave her some medications to manage her agitation in the hospital, an antipsychotic. They gave her Valium, a long-acting benzodiazepine for muscle relaxation, all appropriate for the vertebral compression fracture and her pain. But she had a respiratory distress and a poor outcome in the hospital that was very complicating to the patient and the family. And we took this case as a learning point to try to improve care for a growing population.
As we go older, medication accompanies us
Yeah.
up to the end.
And I think the case examines that, yes, we're managing her illness, the vertebral compression fracture, her pain, but the complications of her COPD were not fully realized, and there was a need to discuss what was most important for her. Was it pain at all costs, understanding that there may be a requirement of intubation that came of it, but those discussions were not had. And the pain medicine, maybe there are different options. Her renal function may have been impaired because of anti-inflammatories. She was given morphine also for pain. Maybe she should have had Dilaudid. So these are very complex decisions that not just one specialty, orthopedics, on a hospital floor can manage. It needs a real collaborative effort for these patients.
But it's not only the collaborative effort, but it also indicates that the utilization of resources is immense for each individual.
Yes.
And this is what you will try to explain to us in the next slide, the role of the federal government in this extensive utilization.
Yes. Right now, especially as baby boomers are becoming over 65 by 10,000 a day and utilizing increased utilization of health care, we have changes happening with Medicare and Medicaid that have just been recently discussed and voted on. And those changes are coming forward, and we don't fully understand the impact yet on Medicaid changes. And then the Medicare changes that are happening is that it used to be Medicare fee-for-service, but now there are increasing Medicare Advantage plans happening with collaborations with insurance companies. So right now, 50% of all Medicare beneficiaries have Medicare Advantage type of Medicare. That's likely to go up to 70% in the next few years. What does that mean for people? I don't think most people understand, both recipients of the benefit, the Medicare beneficiaries, patients and families, and clinicians don't understand. They're ordering treatments, resources to be used for the diseases, but they don't understand perhaps that patient doesn't qualify for rehab outside of the hospital or doesn't qualify for certain medications because their plan will not allow it. And they may need to do other steps to get. So there's a lot of change in Medicare and a lot of change coming forward in Medicaid, and many of our patients over 65 are dual eligible. They get both Medicare and Medicaid, and we need to have processes in place that help clinicians care for their patients better and our hospitals to care for their patients better. We're all somewhat in the dark here, I would say, both patients and clinicians.
But I think in particular the patients are in the dark. They really don't get it. So I have a feeling that from your experience on the floors, you may see it more frequently. That the family is confused. What they need to pay, what they cannot pay, what they should pay. I mean, how do you handle it?
Yeah, it is. It's an exceptional challenge, and Dr. Carney, you alluded to, the environment around us seems to be changing day after day, week after week. It's tough for everybody to keep up, not just patients or equally importantly, their caregivers, but the frontline teams as well. Which is why having expertise and having teams that rally around the care of this patient population that can stay abreast of the updates, of the demands, of the challenges that are being kind of foisted upon us to some degree is of the utmost importance. But you're right. I can't imagine that the average caretaker, the average patient is going to be completely up to date with what is being expected of us. Which is why it's important for us as a health system, as a healthcare team, to provide that information to our patients and families as best as we possibly can. At the core of it all is the emphasis on trying to do what we can as efficiently and as with the highest level of quality as possible. And lucky for us, even though we may not know exactly what is being asked of us at any given time, we have the answers to the test, and I think it really does center around providing that holistic, age-friendly approach with leaders like Dr. Carney and her team that can effectively deliver that to our patients and their caregivers.
Thank you very much.
Dr. Carney, you also, I remember you telling me you had additional training for this in the Health and Aging Policy Fellows. So in that, you really focus a lot on the policy piece of this?
Yes, I did a year as a Health and Aging Policy Fellow, and my placement was with CMS, Centers for Medicare and Medicaid Services, and I learned that Medicare was established by President Johnson in 1965, and it by law, and it provides an incredible amount of services, payment, standards of quality, and we really have to be very grateful for Medicare. It also provides support for education, for fellows, for residents, and I don't think people fully understand CMS's role across healthcare fully and how much it affects all patients. And one of the number one questions I get from patients and families, what does Medicare pay for help? And it's very limited, actually, Medicare, so it gets confusing what Medicare provides. It does provide health care in terms of clinical support and payment for your doctors and ambulatory and hospitalizations, but for custodial care, personal care, it's limited unless it's right after a hospitalization. So there are these nuances to resources and services that is hard to understand. But we hope that we can help patients and families clarify it. Navigate it.
I think that I'm sorry.
No, I was going to say navigation, that is the operative word here. Navigation and quarterbacks that can help to lead the charge.
Right.
It's so important.
Based on my own experience, healthcare was divided into two. The administrator did the utilization and the policy, while the clinician provided care. This is the theory. But I think in the last 20 years, with CMS measures, in particular CMS, they combined the two variables, the finance, the utilization, and a particular disease or diagnosis. I'm not talking about DRG. I'm talking about the combination of utilization and the disease in terms of comorbid conditions. This changed because for the first time, the clinician had to provide input into utilization. Because who defines morbidity? You do. Who defines the scope of the disease at that particular moment in time? You do. And this is where the interchange is taking place. I also think that Medicare is not doing a good job in terms of explaining to the population. As a recipient of Medicare, I get a thick book once a year about Medicare, and then they're telling me, oh, let's save paper and put it on your computer. So you can imagine an average person playing now with the computer and trying to figure out which page to look at. It doesn't make sense. So,
I think that is a great suggestion to CMS to make it more
friendly.
user-friendly, transparent, accessible of understanding the benefits.
I also think that, touching on what you said, Dr. Cast, we're the providers in the hospital, we're the ones who see how these policies really impact our patients and families. They experience it, but then we see how it impacts their health. So as those who are, familiar with it and experiencing it in the hospital and in the outpatient setting and the subacute rehab, how those few hours of home health aid change the lives of our patients. It's also our responsibility to advocate on their behalf and do programs like this to educate others.
Absolutely.
And to your point, the value of a home health aide for someone who needs it is incredible. And as social care may decrease, the backup for social care is healthcare, hospital. Right? We saw it in COVID when nursing homes were closing, community-based organizations were closing, hospitals became overwhelmed, and we couldn't move people to homes if they didn't have the support. So I think that highlights, we see the impact of family caregiving, home health aides when available.
I think it's more than that, a little bit, because the reason, Mike, now I understand why I asked you about the aging program. Because in his experience during COVID, you all of a sudden realize that the central or the key process and system that existed is the hospital.
Right.
Not the insurance companies, not the government, nothing. It's the hospitals. They had to become creative and figure out how to take care of this problem. From disease to mortality, mortality to the funeral. It's absolutely amazing. And this is what changed really. And I really hope as you change in medical care, hopefully you'll be able to shape the government, the policy, because they have to change too. They cannot be what they are. It doesn't work. I mean, you can change the mortality, yes. But you need to change the whole approach in terms of the methodology for taking care of these patients.
I think this slide really speaks to
Yeah.
what
I
you're
think
saying.
so too. I think we're discussing it as we have uncertainty in the policies and the regulatory requirements that are around us. We understand that we appreciate that we have an increasingly complex patient population and an increasing number of needs that will come about from both patients and caregivers alike, inside of the hospital and most importantly outside of the hospital as well. So we have uncertainty, we have acceleration there, but just in terms of raw numbers, the population is expanding. I've been fortunate enough to be in a number of talks with Dr. Carney. We hear the phrase, the silver tsunami, not infrequently. And even here locally, here at Northwell, this is data that's provided to us by our strategic planning group. We see what's to come down the road in terms of our evolving patient population. The left-hand side of the screen looks at our ED utilization, the right-hand side looking at our inpatient discharge volume. I'm not going to go through the numbers in great detail, but we'll see is that over the next 5 years and certainly over the next 10 years, the relative rates, the relative numbers of patients that are coming into our hospitals seeking care over the age of 65 are going to increase significantly, upwards of 10 to 20%, depending on the site of service that they're receiving here in the hospital, patients over the age of 65. At the same time, we are also seeing that we are anticipating that hospital volume as a whole is going to decrease ever so slightly, and that to us may suggest a trend towards a movement of care from inside of the hospital to outside of the hospital. Some of the more routine care, perhaps, we're already starting to see it at urgent care centers, ambulatory care centers, ambulatory surgery centers rather, and certainly in the more routine outpatient setting as well. In short, the landscape here locally within the hospital is changing, the complexities are changing, and the population is getting older. And to your point, you mentioned kind of the hope of getting that streamlined handbook to understand what Medicare can do. If I could ask you one better, if we can get one for our inpatient teams as well, so that we can understand in layman's terms what we can expect and what we can provide to our patients, not just here in the hospital, but most importantly, at the time of a transition of care. Boy, I think that would be great too.
Talk about a growing population over 65. It's a celebration, right? We are living longer. And what that means is we're living longer with multiple conditions. So we have a growing population with multiple chronic conditions. And there may be an acute event that may cause somebody to come to a hospital, which we manage, but how does it impact the other illnesses, like the patient case we discussed at the beginning? So we have a growing population with multiple conditions, multiple medications, functionally maybe impaired, who wish to be treated a certain way, and it becomes hard as we're such a specialty-driven healthcare system.
Well, it's hard in terms that the patient or the population want to live longer. We do want to
Yeah,
live
sure. That's what we're all here for, longevity, right?
And you hold the keys on how to live longer. This is what I think. Everyone looks at the formula. What is the formula for longevity? Is it drinking red wine, having dark chocolate, living in the mountain, eating yogurt? I don't think so. I love yogurt. My wife likes dark chocolate, but it doesn't make a difference. What really makes a difference is that how we interface with the healthcare system. The healthcare system has the answers in terms of technology, in terms of knowledge, research, and interaction with the patient. So we do need, as I see it, have more gerontologists to simply help us live better as we get older. It doesn't mean that you can tell us, oh, you can live another 20 years. We are living longer. But can we live better? Can we live and have a quality of life in the 80s as we had in the 60s?
Right.
Simple things like walking or dancing. And the answer is really with you. We have to figure it out. So the next question, as we get older, how do we stay healthy and out of the hospital?
So as we get older, how do we stay healthy and out of the hospital? Aging is really about managing conditions as you accumulate them over time. And there's a graph we have here from Dr. Shinmura, a cardiologist, that really, I think, helps depicts aging, and our goal is to push that normal aging curve up as high as possible so that we are independent. So healthy aging means exercising, keeping our muscles as strong as possible, healthy living, having a social network that is supportive of you and healthy behaviors. There's ways we accelerate aging, It could be through injury, through smoking, through sedentary behavior, can accelerate aging, and we want to avoid that. But when you start having chronic conditions, you want to make sure that it limits your decline as much as possible. So managing those conditions over time, being connected to clinicians that you trust in a system you trust, so that you're managing complications or problems early, not late. And so you keep that curve high and you're independent, and that frailty disability phase is shorter. That's called compression of morbidity. That was many decades ago. Dr. Fries came up with that term, compression of morbidity, where we want to stay strong, healthy, and active for as long as possible. But it's both healthy living, safety, preventing injury, surrounding yourself with social network that is supporting that healthy behavior, but also being connected to health care that can help manage your illnesses as best as possible.
I also think back, Dr. Carney, to that patient you presented initially, and that long list of medications that she was on. And one unfortunate thing that brings patients to the hospital is polypharmacy, like we were discussing. I think that model of care that we've learned, the specialist model of care, is really evident in that patient. Each medication she's on, there's a block of medication she's on for one condition and a block for another. I think that, unfortunately, that model of care is no longer serving this population at a certain point. And instead a more holistic approach is necessary. And I think that the geriatrics allows us, our approach allows us to zoom in on what matters most to our patients. And I know you'll be discussing that shortly, so I'll turn it over to you.
But you're raising a very important point. What you are saying is that we cannot fix everything. And the graph really illustrates, if you look at the difference between the normal aging and the accelerate aging, the graph is very different. It's almost contradicting each other. So as what it sounds like, maybe I'm wrong, but with normal aging, as you get older, the functional capacity needs to increase. So there is a close correlation between functional capacity and aging. So in other words, whatever disease you have, if it's CHF, let's say, and you are limited for different reasons, you need to do some exercise to improve on the functional capacity. Am I right? Am I reading it correctly?
Yes, there is a aging physiology of all our organs, heart, lungs, bone, skin. Our personality tends to stay the same over. I feel the same I did 20 years ago, right? I imagine I'm going to feel similar 20 years from now. But there is a normal aging physiology, and we want to optimize that over time, staying as your heart as strong as possible, your lung capacity as strong as possible. So there is a functional decline, and any exercise, any activity helps slow down that decline.
I think you're right. We can't fix everything. We don't have that ability. If we could, we would, and everybody would live long, healthy lives. One of the general principles of caring for older patients is making sure that the therapies that we're providing, the support that we're providing, is meeting the need at that point in time. And those priorities change as patients get older. The care of the heart failure patient at age 45 is very different than the care of the heart failure patient at age 85.
Who has 5 other conditions.
Right, because of those reasons and for those reasons. So how can we make sure that we have people leading the charge of that patient's care, and helping that caregiver along, such that we're not adding more to an already complex environment and that we're doing the things that are necessary to remove the risks, or at least limit the risks of causing more harm than good in the management of those conditions. So I think that's a big piece of it as well.
And it's really hard for frontline clinicians because the population is so heterogeneous. You could have a 65-year-old with 5 of those other conditions who's really chronologically 65, but health-wise, physically, you know, 9, right. And then at the same time, you could have a 90-year-old who ran a New York City marathon,
Right.
you know? So it's hard for clinicians to, we want to, age helps us kind of high level say you have multiple conditions, but not everybody's on that graph at a different place, and it's very hard to,
So,
and going back to that graph,
yes,
that
correct.
where you are on that line may depict what reserve you have. And that reserve you may be using to stay independent for as long as possible, but you may get that urinary tract infection, and that tips you over, right? We call it homeostenosis with age. We see that with patients that come in, they were fine last week, something happened.
Yes.
And it's just, sometimes it's the reserve that they used to have is just not there.
Right.
And that's what we're trying to reserve, so that you can handle stress. And that's the definition of frailty, inability to manage stress. And that's a definition. So that's how we try to explain to families. Frailty is here, their ability to handle a stressful event, an infection, right? A surgery is harder to handle if you're in a frail state. And we need to have those discussions about framing the challenges in this state.
Yeah. And I think that functional reserve that you mentioned is increased by those touch points with the healthcare system, you know, staying on top of your chronic conditions, avoiding that harm that you mentioned, Dr. Cast, and you know, those are the things that will help us go to the top curve there for normal aging and decrease that risk of frailty.
So if you look at the next slide, in terms of what matters most, a care plan are complex. So would you put in the care plan this reserve that you're looking in patients as part of the goals
I think
in terms of teaching?
I think it helps patients and families better understand their treatment options and the risk of treatment options. So that helps establish care plans. So if you're in a frailty state, understand that a major surgery has great risk. It helps better understand than the treatment plan.
You have to remember, we don't want to admit that we are frail. This is the problem. The problem is that do we have enough of the psychology of understanding this patient population?
Do we have the psychology and do we have the research here?
Yes.
And we need more research in this space because a lot of these patients are excluded from clinical trials. Frailty, comorbidities, they're excluded. So we don't have the psychology or the...
And the manpower as well. Many geriatrics positions go unfilled, and you know, I think it's a very rewarding field to go into, and maybe we can do more to make it more appealing to trainees,
Yes.
so that we have the workforce to address those needs.
Absolutely. Absolutely. Because you can be a surgeon and geriatric medicine at the same
Yeah.
time, because this is how it works, right? But the surgeons don't see that in that way. They see themselves only as surgeons. It's really fascinating. I would love to interview orthopods who do knee replacement. Do they understand the aging process too when they do knee replacements? Because the recovery is so long for some patients that it's really, to be frail plays a major role here.
Yeah. And not to be negative, but maybe we'll learn that doing a knee replacement on someone frail gives them more ability to be more robust later.
Correct.
Right?
But we
I
don't
don't
know.
want to, we don't know.
Yeah. So how do we develop security for a growing vulnerable population? This would be the next question.
I really believe the innovation that's needed in this space is an age-friendly health system, a framework. And I'm just going to read a quote from the book. I think everybody agrees that we needed a more systematic approach to improving care for older people across the entire health system. Terry Fulmer told us, and we interviewed her. She's CEO of John A. Hartford Foundation. We now have over 400 peer-reviewed papers in the literature about the work. It's just taken off like a rocket, and that's because it simplifies the approach to care, regularizes the care, and promotes quality and reliability. So what is age-friendly? The framework is 4 M's. What matters most, medication, mentation, mobility. And these are the core health issues. It is evidence-based, and it's a way that not only helps outcomes and patients, but it helps the care team, the frontline clinicians, address the multiple issues. And if you start with what matters most, it can help align the medication usage. And if you screen for mentation, delirium, depression, dementia, it helps understand what you're caring for holistically. And mobility is keeping people as independent for as long as possible.
So in the next
Safely.
slide, you really operationalize those
Yes,
variables.
yes.
So Becca, could you make a brief comment on that?
Yeah, so the age-friendly healthcare system is an initiative through the Institute for Healthcare Improvement. It's evidence-based, and if you do all 4 M's together, you exponentially increase the quality. But individually, each M is evidence-based tied to improved outcomes, decreased readmissions, decreased injuries, decreased length of stay, decreased cost of care too. And if you align the care plan with what matters most and the medication usage with what matters most and trying to avoid potentially inappropriate medications as we age and the right dosages, we're going to decrease adverse drug events. So it is a quality initiative, patient safety quality initiative, along with a decrease in the care team. It's a great framework to start with.
Yeah, I think you laid it out really well, and there's a couple of key words there that I want to highlight. Systematic, evidence-based, and it's patient and caregiver centered at the forefront of it all. So it's a great approach. It's rooted in science, but it's also something that's really easy to rally around, right? It's at its heart of it, it's just doing the right thing, and having an appreciation for the challenges, the uniqueness of caring for an older patient population. And with that, you can have tangible outcomes that improve not just the quality of life, but the quantity of life for your patients at the same time. And I agree with you, putting kind of the framework of what matters most kind of at the center of it all, and almost having everything else revolving around that, that can be so impactful. Using that as a point in time to stop and ask questions so that the care plans are aligned moving forward. It's not only doing the right thing for your patients, but it gives us the chance to have the patient and the caregiver come along for the ride as well. So we talk about kind of setting the stage for what's to come down the road. The 4 M's are a great model for just building off of, both in the inpatient setting and certainly in the outpatient setting.
But what patients and families are often getting are 20 different care plans from 20 different teams. And that's very hard for them to process. And not just them, also when patients go to a skilled nursing facility for subacute rehab, there are 20 different care plans the nurses there have to implement. We would like to think we're creating this one general care plan, but it's not always the case. It's becoming increasingly complex. So that's why what matters most helps prioritize what to do first.
Right. And this is really illustrated in the next slide on the data.
Yes,
It's expressed. This is the beauty of your work, is that it's not theory. It's not opening a book and reading, but it's practice. What all you're saying is practical. And this practical process can be quantified, right?
Yes.
In this database. So
for each M, we have an evidence-based tool that we have taken guidance from the Institute for Healthcare Improvement, and then we are making sure our teams are utilizing each evidence-based tool for each M, documenting, and then through that electronic health record, we're pulling and measuring each of the M's. And we're looking at outcomes, length of stay, disposition, mortality, readmissions. So for what matters most, we've done the most work on for this. Our evidence-based tool are goals of care conversations. And in that goals of care note and template, we have in there written what matters most to you to help generate a discussion. So our goals of care note is not about advanced directives, although that often comes out in these discussions. And so there's a billable opportunity there that we've built around. But it's really about developing the care plan direction. And what we have found is we started measuring if it's done in the emergency department, the goals of care conversation, or in the floor once they're admitted. And you'll see at the bottom, so at the top right is orange, is it's done in the emergency department. And this is across all our hospitals. But we started this at just one hospital, we did it, and we saw that if they had conversations in the emergency department, the length of stay was lower and the readmissions were lower. Now we have, not all of our hospitals are as performing the goals of care conversation in the emergency department. So this is somewhat diluted, but we're even across our health system seeing that length of stay is less if the goals of care conversation is held in the emergency department, where you start the care plan and the direction.
no, what you're really showing is that you have evidence-based practice
Yes,
in your database.
yes,
And as a manager, you can change things. You can use this as a tool to teach fellows and residents. You have as a tool to teach other disciplines about what is going on with your patient. So this is terrific. So what is really happening also, that the combination of statistics and medical knowledge, which is a key. I mean, people shouldn't think statistics overrules clinical judgment. Clinical judgment is clinical judgment. It's always independent. But the statistics can become a supportive tool. Am I right?
Absolutely. I think this is such powerful data to empower our teams and to really get that positive feedback loop going when we're doing the right things for our patients. You know, if I can demonstrate to my hospitalists that when we are holding goals of care conversations and addressing what matters most with increasing frequency, we stand to reduce readmissions for patients coming back to the hospital. Man, that is impactful. We can reduce the length of stay on our inpatient census. That's amazing. And then, you know, if I take my hospitalist hat off and put on my associate medical director's CMO hat, this also helps to make the business case for what the things that we are doing. If we can demonstrate that by having these conversations with increasing frequency in the emergency room, that we can, you know, reduce our hospital occupancy, let's say, or reduce the likelihood of a patient going back to the hospital, which has other financial implications pertaining to CMS and other entities as well. Then I can use that information to make sure that I'm resourcing these efforts appropriately, that we're staffing teams in the right locations, that we're adding geriatricians and palliative care physicians to the fold so we can do this with more frequency. As you can see, we still have room to improve upon. 29% is a good number. But boy, I'd love for that number to be even higher. Making sure that we're getting there is going to be very much important, and it's going to translate to real outcomes for our patients.
We did not want to ask our frontline clinicians to do more work or added work without showing that it impacted outcomes. Right? So we wanted to align what they were doing in a way that improved the mission of the hospital. So we started in one hospital, Glen Cove Hospital. We created the dashboards for each of the M's. Mobility is AMPAC. Delirium, we're using CAM, ICU, and BCAM for the floors. And medications we're working on. We have a medication report, but it's not, the dashboard is coming still. But we're showing impact. So now we're spreading it to other hospitals. And the leadership of our health system said, okay, you did a community hospital. We want you to go to Long Island Jewish Forest Hills, which is in Queens, a very diverse population. We're showing impact there, and now they've asked, let's work with North Shore University Hospital, which is a quaternary hospital. So if we're trying to show that this framework in different environments, in different hospitals, is effective, then we can spread it widely. So I just want to clarify that age-friendly care, it is our goal to make all of our hospitals age-friendly. As people come to our hospitals to address their acute illnesses, that we are keeping them as healthy, not declining, and not contributing to accelerated aging because of a hospitalization. We want to manage all of their conditions collaboratively, minimize harm, and create a care plan that can be followed when they go home. And the goal is to go home.
Mm-hmm.
And we've been showing it at a community hospital, a tertiary hospital, and now we're doing it at a quaternary hospital. It's really making the hospital age-friendly.
Yep. And we have quality management tools to do it.
Yeah.
And you'll talk about one of them, which is the performance improvement coordinating tool.
Absolutely. And just to give a little context, so Dr. Carney and her team over the last few years have really helped to provide these data to all of our sites throughout the health system. Even though the pilots may have been individually hospital focused, all of our hospitals in our 23 and growing hospital-wide system have access to these dashboards and can use them to their advantage to shape and change their process improvement models. So our hospital has been a part of Dr. Carney's Advanced Illness and Aging Collaborative for a number of years, and hearing about a lot of these great things that were going on. But really over the last 6 months or so, we have tried to accelerate that and bring the age-friendly philosophies that are discussed at that high level into our hospital and start to really permeate throughout the entirety of the institution. That's been further accelerated by some of the changes that have been going on in government. So for 2025, CMS has actually made it an expectation that all of our hospitals are participating or have an age-friendly structure in place. So although it's the right thing to do and something that we've been looking to do for a number of years, it's now the expectation. This is the standard of care, at least as far as CMS sees it, and certainly as far as I see it as well. So with that, we kind of took stock over the last 6 months or so of some of the things that our hospital itself has been doing kind of in an age-friendly vein. We have had initiatives centered around early mobilization and getting our patients up and moving around to decrease the risk of falls, but also to increase the likelihood of a transition of care back into the community, preventing patients from becoming debilitated while they're here during their hopefully short inpatient stay. As mentioned before, we have taken strides in trying to enhance our palliative care presence downstairs in the emergency room to advance those early goals of care discussions. We've been fortunate to train up and hire a number of geriatric hospitalists to join our ranks over the last few years as well, have put them onto dedicated units caring for patients with geriatric conditions, comorbidities, et cetera, on focused care models that have structured interdisciplinary rounds that really emphasize the 4Ms approach for all of our patients every single day. We've had a trauma surgery co-management program with geriatric hospitalists embedding themselves into the care of the surgical patient to align with the 4Ms approach as well. We've taken strides to align our transition of care workflows with our outpatients geriatrics office just down the road, a supportive oncology practice, and our outpatient palliative medicine partners as well. We work closely with skilled nursing facilities. We've taken efforts to screen patients in the emergency room for abuse and neglect, particularly our most vulnerable hospitalized older adults. And we've built upon these to actually obtain high levels of certification over the last few years, whether that's more recently becoming a niche exemplar or our geriatric ED accreditation, which have been fantastic accomplishments. At the heart of it all is a lot of these things, though, are still relatively siloed. We're doing geriatric care on geriatric units or age-friendly care on geriatric units. We are providing co-management to trauma surgery patients, but maybe not our orthopedic surgery patients, for example. So with kind of the expectations from CMS, the great work that we're seeing across the health system, we made it a priority really at the beginning of this calendar year to kind of coalesce a lot of that great work that's been going on, share best practice, and put structure around it such that we can disseminate and spread that with increasing velocity throughout the entirety of our house, knowing that the aging population is only getting older and with higher frequency. So,
And I'm sorry to interrupt you, but it all reflects in the next slide on the data.
yeah.
So you want to make a comment on that, on the data?
Yeah.
Because you have care plan goals, documentation. Why is it so important to look at the statistics?
So data drives everything. If we can't put numbers behind it, it's tough to enact meaningful change. There has to be some objectivity to these essentially subjective conversations that we're having. What matters most, making decisions about medications, et cetera. We put care standards around it. We put evidence around it. But the data is what drives us. And it's important twofold. One, in helping us to set the stage for what we need to continue to improve on moving forward, but also for us to assess our performance and to make sure that we're adjusting our goals appropriately or adjusting our initiatives that are going to change our outcomes appropriately such that we can get to where we want to be. So as mentioned by Dr. Carney, our health system has these excellent dashboards that allow us to drill down at the site levels, but our hospital, being a quaternary care center, caring for an aging patient population, whether that's in the fields of advanced cardiac care, transplant surgery, advanced neurosurgical care, etc. We have our own set of priorities. We have a unique patient population. We have unique care teams and structures and institutes and programs, etc., wrapping their arms around these patients. So while the system level dashboards give us a great place to start, we thought it was important for us to have kind of our homegrown dashboards as well and some of our own data. This is just a snapshot of some of the things that we are currently measuring and reporting out at our Performance Improvement Collaborating Group on a monthly basis with key stakeholders that are assigned to each of the domains. So we have working groups centered around what matters most: medication management, frails, falls, and mobilization, mentation and screening, social vulnerability and community support champions, as well as what I mentioned before, our niche structure and our geriatric ED structure.
What do you think about when you learned about process variables and the STAR program with the quality? Do you, in your head, do you see a relationship?
I'm so impressed by this data and this body of evidence that we've collected. I mean, what speaks to me the most is not only do we have, the data to back up that this is helpful for our systems, helpful for our hospital, but we can feel good about what we're doing because we know the patient satisfaction, numbers are high, the families are happy with the care we're giving because of these metrics. And it really aligns with the values and goals of all of our patients. So I love that, you know, not only do we have the evidence that it's helpful for our population, but we can feel good about what we're doing as we integrate it.
And I think that's will be interesting if we can measure in the future the impact on the frontline clinicians. Because when you go to Dr. Cass' PICG, age-friendly PICG, there's this energy in the room, right? There's like, they feel like there's control, where can be a lot of moral distress by frontline clinicians caring for somebody with multiple medical problems. Where do I start? What do I do? But I think there's something here that we're going to start seeing an improvement in clinicians. We don't have that research yet.
Now we're going to the conclusion of the session.
Yep.
And we are ending out with the book that you wrote. So I don't know if you want to make a comment.
It started out with Michael Dowling wanting to learn more about aging, and I think you're right. I think it did come after the COVID experience, and there was more to this. So that discussion and outlined the book. So I'm very proud of this book, and I'm proud of having been able to work with Michael Dowling, who has started this aging revolution as a healthcare system. We held an Aging Revolution Summit in December, and we had leaders from across the nation. So I'm proud of the book and this experience. And what I will say is, you can't do this work unless you have leadership buy-in. And I think, Dr. Cass, you see it at your hospital, you have the support. The health system has supported this, our efforts. You need the clinical expertise, geriatrics, palliative medicine, quality, social work, physical therapy, pharmacology, everybody. You need that interdisciplinary clinical expertise available. It's all interdisciplinary care here that's needed. You have to align existing programs and services that you have in this space and empower them. And now we're looking to move it to the community, to partner with community organizations, clinical practices, to continue this work when patients go home, to help support them and their families. And that's where we're moving towards next. So it's a revolution, and our hope is you'll join us.
You have a last comment you want to make?
No, well, first, just thank you for this opportunity, and I know we talk all the time, but it's great to talk in this forum as well and really share some of the great work that has been going on throughout the entirety of our system, and I'm honored and privileged to share some of the work that we're doing here at North Shore. Putting the structure, putting the framework around it is step one, and I hope that we have identified the need here and the use case for putting these sorts of models behind the care of all of the patients that we're caring for here in our hospitals. I'm really excited to see where this is going to go moving forward. I think with that structure, we can only build upon it. We can only identify new opportunities. And we're fortunate to be part of a team and part of a system that is going to continue to support that change. And again, thank you for this opportunity. Thank you.
Absolutely.
Yeah.
You have a last comment?
I'm just really grateful to, be a part of this field, and I too am excited about, changes to come, and hope to make a positive impact on this population.
Great.
I wanted to say thank you to all of you, because you not only gave us the why to do it, but you gave us the methodology to how to do it, and really change the culture from the front line with the leadership support, having the quality data, that we can make a difference if we get on the revolution with everybody. So thank you all.
Thank you.
Thank you.
Thank you.
We'll now be moving on to Q&A if there are any questions from the audience.
Maybe I'll just fill the void for a second,
Sure.
in case people are are typing their questions away. Thanks again to the team and allowing us to have the opportunity to share some of the things that we're doing at Northwell and specifically at North Shore University Hospital. I hope it was informative and kind of gave a broad strokes overview of why we're trying to accomplish what we're trying to accomplish. And I actually right before this call, there was a call that was held by HINES, which is the Hospital Association for New York, specifically on the topic of age-friendly healthcare and some of the new CMS regulations that have come into place and how hospitals can work towards starting to align with those standards. And really, again, validating. And we oftentimes joke about how CMS is making us do this or making us do that. I'm really proud that CMS has taken this under their wings and made it a part of the standard of care for all the hospitals across the country. It's so impactful. It's as I mentioned kind of in the talk, it's something that it's very easy for people to rally behind. And with great leaders like Dr. Carney, it makes it even much more so worthwhile. So
Yeah.
thanks again for the opportunity.
Yeah, thank you. I want to thank Andrea Restifo and Dr. Delugash, who was on the video during the interviews. And, if I have one point to stress is partnership, collaboration, interdisciplinary care. And if you have questions, happy to talk to other systems. Invite you to witness the PICG that Dr. Cast leads at North Shore University Hospital or any of our hospitals that are having these age-friendly performance improvement coordinating groups to see how we do it or explain further. So I'll open an invitation to help other places on this journey. And Charles, always a pleasure partnering with you. So thank you.
Thank you.
Maria and Charles, there is one question in the Q&A if you all are able to see that.
Yes. Why was trauma surgery designated rather than perhaps orthopedics, which impacts a great percentage of the aging population? That was
it's a great question. So part of it was at the time it was developed strategic in where the biggest gap was. We've had geriatric orthopedics co-management programs at other hospitals within the system. And we have hospitalists here at North Shore who have been involved in that care at other sites within the health system as well. The relative volume of orthopedics, specifically here at North Shore is on the lower side relative to other sites within the health system. And we've also seen a shift in care moving away from the hospital and into the outpatient setting. The majority of the more routine orthopedics care is now done in ambulatory surgery centers, which certainly has, there should be an impetus there for geriatric focused protocols and collaboration, et cetera. But really, it's moved a little bit more out of the hospital and into the outpatient space. So part of the decision was centered around that. Part of it was also based on where the biggest need and where the gap was at our institution. As a growing level 1 trauma center, we were able to kind of study our patient population and quickly identified we are not the trauma center that comes to mind when you think about trauma centers. We are primarily a geriatric trauma center. The typical patient that we care for on our trauma service isn't, fortunately, the motor vehicle collision or some other high impact trauma. It is an older patient in the community who unfortunately had a fall or a complication, who happens to be on a blood thinner or 2 or 3, who came in with an intracranial hemorrhage or a rib fracture or the compression fracture that Dr. Carney mentioned at the beginning of the talk. There's tremendous value in developing that program. It helps to meet the need of our organization. And actually now it's been reverse engineered, similar to how CMS is approaching age-friendly healthcare, that TQIP, which is sort of the governing body for accreditation around trauma surgery and trauma surgery verification, now actually require there to be a geriatric co-management program or a geriatric liaison helping to manage that patient population. So we're actually a little bit ahead of our time. Maybe they stole it from us, maybe they borrowed it from us, I don't know. But we've seen immense outcomes associated with that program in terms of reducing inpatient mortality increasing the number of goals of care conversations our patients are having, decreasing polypharmacy specifically on the day when patients are transitioning out to the outpatient setting. It's been really impactful for us. So it was the right program for us at the time. It's not to discredit the GoCo model and the orthopedics co-management model. That's a great model as well. But as far as what we needed at that point in time, trauma sort of fit the bill.
Right, and I just want to explain, Dr. Cass is Associate Medical Director at North Shore University Hospital, one of our flagship hospitals, and that 4M framework for age-friendly can fit into many different models, and it allows flexibility for each hospital. So he was describing one program that aligned with an age-friendly framework at his hospital, but some of our other hospitals have other programs that align, such as GoCo. So I hope that helps clarify, but it by no means are we excluding the orthopedic population. And interestingly, over 65 population, 75% of traumas are related to falls at North Shore University Hospital. So hope that helped. Let's see, another, we got it. Thank you. Thank you, Guy.
You.
All right, I don't see any other questions unless, Charles, you want to sum up anything?
No, again, just an immense amount of thanks to you and the team from ACQM, and appreciate the time and the opportunity to share some of the things that we're doing here.
Yeah, thank you. Interdisciplinary, that's my key phrase for this session. Thank you. Melissa, I don't know if we, how you want to proceed?
I'm ending it now. Thank you, everyone.